Welcome to NU 623 Adult Healthcare, Unit 2, Presentation 2. This lecture will be on peripheral vascular disease, deep vein thrombosis, and chronic venous insufficiency. Again, please go ahead and look at the chapters that are associated with these diagnoses in your book because the lecture is only going to give you highlights. In your evaluation for peripheral artery disease, you have to understand that 50% of your patients are not even going to be symptomatic, and there isn't any routine screening recommended per the ADA unless the patient is diabetic and greater than 50 years old. If they were symptomatic, these are the things that you might hear as symptoms or signs on your exam. The lower extremity intermittent claudication. Now, claudication is usually going to be worse with exertion, and then it eases with rest when it's an early disease process. As the disease progresses, the pain comes with rest too, and this will signify that you are dealing with severe disease. Pain, aches, cramps, coolness, or tired feeling, diminished or absent pulses, increased capillary refill. You might see these things. They could have abdominal, femoral, or popliteal bruits on exam. The extremities may have pallor, but with severe disease, they will have dependent rubor. Paresthesias or paralysis may be a sign. Thickened toenails would be likely. Muscular atrophy and hair loss on the extremities. Your diagnostic evaluation of peripheral artery disease can start with giving your patients the walking impairment questionnaire, and this is talked about in your text. For diagnostic tests, you start with the ankle brachial index. The ankle brachial index, or the ABI, is the ratio of the ankle systolic blood pressure divided by the brachial systolic pressure, measured using a Doppler probe. Normal ranges are going to be 0.9 to 1.3. If you have below 0.9, you're looking at PAD. If you have above 1.3, you likely have calcified vessels. If the ABI that is resting is done is normal, but your symptoms still point towards claudication, then do an exercise ABI. If that result is decreased by 20%, you're going to want to order additional testing. The toe brachial index is a good indicator, a reliable indicator in patients who have diabetes. So going on to additional testing, the duplex and Doppler ultrasound can provide location and severity of any stenosis of the vessels. Your magnetic resonance angiography is a really highly sensitive test for location of lesions too, but a CTA is also an option. When managing patients with peripheral artery disease, you are going to have your treatment aimed at improving the blood flow in that limb to reduce the risk of further ischemia and treat their symptoms. Now you're going to want to control the hypertension, diabetes, and hyperlipidemia that might be comorbid in these patients. Encourage them to quit smoking, get them to exercise, manage any ulcers or lesions they have on their leg. When it comes to medication therapy, antiplatelet therapy is the treatment of choice. It's usually going to be either aspirin or clopidogrel. Sometimes you will have patients on dual platelet therapy based on certain risk factors. For symptom relief, the American Heart Association recommends silostazol. You can also use pentoxifylline. The silostazol vasodilates and inhibits platelet aggregation, but you cannot use this in heart failure patients. You're also going to want to make sure they're on a statin if they've got a lipid disorder, and then some options for revascularization depend on the level of the obstruction, but here you would get a vascular surgeon involved. Your follow-up on your patients is going to vary with the severity of the PAD, any presence of comorbid conditions such as diabetes, or a history of revascularization. So annually, you're going to follow up on patients who are non-functionally limited, or those that have a limited lifestyle but they're responding well to conservative treatment. Once they've had a procedure done, they're going to need frequent visits for the first 2 years, and that'll be directed by the vascular surgeon typically. Then they'll be seen annually according to the ACC and the AHA. All other patients you're going to see every 3 months. Unless they have ulcerative lesions, you may need to be doing weekly visits on them. For referrals, your vascular surgeon is going to get involved if you need any kind of procedure done. You may need to send them to the wound clinic if they have non-healing ulcers. Critical limb ischemia, gangrene, or ulceration or pain at rest are present, you're going to want to get them into specialty. When you're doing your evaluation on your patients, if you suspect that there might be a DVT, think about asking them questions surrounded around Virchow's triad in your HPI. Have they had a period of immobility, which can cause venous stasis? Have they had some kind of an injury to that limb, which could have caused the thrombosis? Are they in a state of hypercoagulability, like do they have a known cancer or an autoimmune disorder? When you do your physical exam, you're looking for pain in that extremity, unilateral edema, tenderness with palpation or palpable cord, warmth, and erythema. Now, initially, patients can be asymptomatic and still have a clot developing. So keep this in mind. One thing you need to know too is that the positive Homan sign, where you have calf pain with dorsiflexion of the foot, is no longer considered a reliable indicator for a diagnosis. Diagnostically, your physical exam is only going to be about 30% predictive of a DVT diagnosis. So it's better to use the Wells criteria, and there is a link right here that you can go right to it. You can also do a D-dimer, but they're highly sensitive, but they're not specific. So the criteria usually says that if you have a low Wells score and a negative D-dimer, you're assured that there's no DVT. If you have an intermediate or a high Wells score, you can skip that D-dimer and go straight to ultrasound because it's pretty predictive that you're going to have one. Now your ultrasound is going to be your definitive diagnostic. If the vein cannot be compressed, it is considered a thrombus. Also, a contrast venography can be done if non-invasive testing is not feasible or the results are equivocal. A CBC should be done. You might see an elevated white count, especially if there's sepsis. A PT-INR and an APTT should be done. Renal functions test should be done as well. If you have any suspicion of a PE, you're also going to want to order a VQ scan or a spiral CT of the lungs. So here's a graph that'll show you the criteria for the Wells score. You have 9 indicators here, and then at the bottom, the interpretation will tell you which is considered a high probability to a low probability. Select patients can be treated as an outpatient for DVTs. You definitely want to educate them about ambulation, get them moving. They need to be wearing compression stockings that are capable of 30 to 40 millimeters of mercury compression. You can order them specifically in that gradient. These are going to need to be worn for at least 1 to 2 years. The initial anticoagulant treatment is for the first 5 to 10 days, they would receive a low molecular weight heparin, unfractionated heparin, or fondaparinux with warfarin overlap for 5 days. You're trying to get that INR therapeutic to 2 to 3 before you take them off the heparins. Low molecular weight heparin can also be given and then followed by oral factor 10A or a direct thrombin inhibitor. You wouldn't give them together. For long-term anticoagulation, any of them can be used, warfarin, oral factor 10A, or the direct thrombin inhibitors. Therapy can last anywhere from 3 to 12 months. It's going to depend on the etiology, and it might also depend on if this is a second instance for this patient. Thrombolytic therapy is used for massive DVTs or PEs or failure of therapeutic anticoagulation, and that would have to be done in the hospital. If you have a patient who anticoagulation is contraindicated in, you can do a consult for vascular surgery and they can put in an inferior vena cava filter. Now, this won't stop clots from forming in the blood, but the idea is that there would prevent them from getting to the lungs. In follow-up to your patients diagnosed with a thrombus, you may need to do another ultrasound in 2 weeks post-diagnosis. This could be because you're monitoring extension of the thrombus, especially if anticoagulation was not chosen as a treatment because it was an isolated distal DVT or there was non-severe symptoms. Or if you're on therapy and there's a concern that there might have been an extension of the thrombus, you're going to repeat an ultrasound. Anticoagulation monitoring is going to be variable. Warfarin is going to be based on dose titrations. Initially, you're going to check that PT-INR every 2 to 3 days. Once you get them on a stable dose, you can check them monthly, except for when dose changes are made, you're going to repeat that INR within 7 days after the change. For low molecular weight heparins or fondaparinux, the only monitoring that is needed is kidney function. IV heparin is going to be done only in the hospital, so they would be checking an APTT for that. Oral factor 10A, the rivaroxaban, the pixaban, or the direct thrombin inhibitor dabigatran, those just need monitoring of kidney function. They don't work on the pathway that you need to monitor the INR or PT. For referrals, if you have a patient with a large DVT or a pulmonary embolus, high risk of bleeding, or they need IV anticoagulation, you're definitely going to have them admitted to the hospital. Vascular surgery may need to get involved if you need to have an inferior vena cava filter placed, or if you have chronic or recurrent DVT risk, if the patient needs surgery for a thrombectomy, or if they have a septic thrombophlebitis, or if they have hypercoagulable states. Evaluation for chronic venous insufficiency includes looking at the risk factor profile of the patient. There are modifiable and non-modifiable risks. Increasing age, being a woman, being a smoker, having a family history of the disorder, and having an occupation with prolonged standing are all risk factors. On exam, you may experience dependent edema, varicose veins, localized pain that may diminish with elevation of the legs. Legs will be complaining of having fatigue or heavy legs. There could be hyperpigmentation, dryness, or scaling. They may have leg ulcers. They may have subcutaneous fibrosis. And you may have normal or you may have diminished peripheral pulses. When you see this presenting picture in clinic, you can usually make a clinical diagnosis of chronic venous insufficiency. But to be sure, your primary diagnostic study would be a duplex ultrasound, because this can localize the site of any obstruction or any reflux in the deep and superficial veins. A ascending phlebography can also be done, but this is used by specialists for complex cases. A venogram can be ordered, and this details venous anatomy, or an abdominal and pelvic CT can be ordered to rule out a pelvic mass that might be compressing the iliac vein. Guidelines recommend conservative treatment for chronic venous insufficiency. And what your goal is here is to alleviate the symptoms. Compression stockings should be ordered to control edema. You can use the lower pressures of 20 to 30. If they have advanced chronic venous insufficiency or they have ulcers, you're going to want to order tighter compression hose at 30 or 40 millimeters of mercury. A mainstay of treatment is to use moisturizer. They have to keep those legs aggressively hydrated. They need to do light exercise, lose weight, elevate the legs 30 minutes a day, several times a day. And if they do have any ulcers, you need to do aggressive treatments. They're difficult to heal. Sometimes pentoxifylline can be used to help to heal the leg ulcers in conjunction with the stockings. If all else fails in conservative treatment, then they may have to have an ablation done. This can be done with laser therapy or radiofrequency as an outpatient. And a more invasive procedure would be a saphenectomy, which is a surgical vein stripping. Follow-up is going to vary just like in a lot of these disorders because it's a chronic condition that requires compliance with compression therapy to prevent or lessen the recurrence of leg ulcers. So based on the adequacy of the symptom relief and how well they're doing with their self-care and the presence or absence of ulcers or worsening disease, that's going to guide your follow-up. You're going to have to use your clinical judgment. As far as referrals, the main referral source here would be the vascular surgeon to be able to do invasive procedures. These are the references that were used in conjunction with this presentation. Again, I want to stress that you do need to read your chapters in your book so that you get the full breadth of the information.